Welcome to EMDR, the science behind the therapy, a podcast from the Sonoma Psychotherapy Training Institute. I'm your host, Dr. Andrew Leeds. In each episode, we explore the latest research and clinical insights about EMDR therapy, highlighting the leading scholars' latest contributions to EMDR research, education, and training. Whether you're a therapist, a student, or a lifelong learner, I'm here to connect you to the science behind the practice of this remarkable form of psychotherapy. I welcome your feedback and suggestions for topics to be considered or any issues you encounter in my summaries of the research. You can reach me through the Contact Me form on any of the websites listed in the show notes. Before we start, I want to draw your attention to the unique EMDR therapy training delivered by Sonoma Psychotherapy Training Institute. Sonoma PTI provides a comprehensive program in 4 two-day modules spread over a 12-week period. These 4 modules include all required hours of lecture, practice, and group consultation. Our Zoom-based program is open to clinicians from throughout the United States, Canada, and Europe. I invite you to look over our curriculum and training schedule at sonomapti.com. In today's podcast, we explore a topic suggested by a listener, the role of EMDR therapy in perinatal health and the treatment of birth-related anxiety and PTSD. The context for this episode emerges from 2 intersecting themes. The first theme involves early cautions about the use of EMDR therapy during pregnancy, and the second theme is the dramatic increase in the number of treatment outcome studies and research reviews on EMDR and pregnancy that provide more up-to-date guidance for EMDR-trained clinicians. To access any of the original research papers mentioned in the podcast, you will find a complete list of references and links to each of these studies in the November 2025 blog on sonomapti.com. Just go to sonomapti.com, click on the blog section on the far right of the menu bar, and then select the November 2025 listings. So let's get started with the background to today's episode on EMDR and pregnancy. In the early EMDR training programs starting in 1990, as well as in the first and second edition of her textbook, Francie Shapiro warned that EMDR can temporarily increase physiological arousal and suggested that clinicians should exercise caution with medically fragile clients, including those who are pregnant. This became a frequently repeated caution by many EMDR trainers and led to widespread hesitancy over offering EMDR therapy to pregnant women. In 2012, a review article by Arch, Demigian, and Chesnick was one of the first to explore the question of safety of non-EMDR exposure therapies during pregnancy. They found a paucity of research on the use of exposure-based treatment for anxiety disorders among pregnant women. They pointed out that more than 75% of pregnant women, including those reporting high anxiety, prefer psychotherapy alone to pharmacotherapy or combination therapy for anxiety. Based on their review of obstetric, psychophysiological, and anxiety treatment literature, they concluded that exposure-based behavioral therapies for anxiety disorders are likely safe during pregnancy, particularly when compared to many pharmacologic alternatives. They highlighted unanswered questions about the biopsychological effects of exposure therapy during pregnancy, including maternal stress responses and neonatal health. In a 2012 article in the Journal of EMDR Practice and Research, with first author Carol Forgash, I was one of 3 consultants who was asked to comment on a clinical inquiry asking about whether or not to offer EMDR therapy to a 7-month pregnant woman with PTSD. She had developed a state of intense anxiety after a tornado destroyed her family's house and tossed her from her hiding place in the basement onto the street. Remarkably, she survived with minor injuries, but in a persistent state of fear. The third contributor, Claire Stamrud, summed up the state of our knowledge. She explained that the few case studies to date, as of 2013, that evaluated EMDR during pregnancy had found positive effects but pertained to women with post-traumatic stress disorder following childbirth, not during pregnancy. She wrote that once obstetricians have been consulted, women have been informed about possible risks and benefits, and given their informed consent, they should be able to choose to commence EMDR therapy during pregnancy. Now, 12 years later, in 2025, there are 9 controlled studies of EMDR therapy for pregnancy-related conditions and 4 review articles summarizing the literature. In addition, 4 recently published non-peer review articles from the Go With That magazine of the EMDR International Association are behind a member-only paywall. You can find a list of all these articles and links to their publishers' web pages in the November 2025 blog entry on sonomapti.com/blog. So let's look at what the science tells us about EMDR and perinatal health. Sandstrom and co-authors published a pilot study in 2008 to evaluate EMDR therapy for PTSD following childbirth. The study involved 4 women diagnosed with childbirth-related PTSD who received 3 to 5 sessions of EMDR therapy. 1 woman was pregnant and 3 were not pregnant. This pilot design focused on assessing clinical safety, tolerability, and initial treatment outcomes using a qualitative approach supplemented by quantitative measures. PTSD symptoms were measured with a traumatic event scale. Additionally, the study monitored maternal well-being, birth outcomes, and participant satisfaction with treatment. Follow-up assessments were conducted at 1 and 3 years postpartum. All 4 participants demonstrated significant reductions in PTSD symptoms post-treatment. No adverse effects or safety concerns were reported. Participants also reported feeling more emotionally resilient and better prepared for subsequent pregnancies and births. The findings suggested that EMDR could potentially be a safe and effective intervention for postpartum trauma, although the small sample size limits generalizability. Sandstrom et al. Concluded that EMDR treatment for postpartum PTSD appeared to be a feasible, safe, and promising approach, warranting further investigation through larger controlled trials. Stamrud and co-authors in 2012 described 3 individual cases of women diagnosed with childbirth-related PTSD who received EMDR therapy during their second pregnancy, tailored to address previous birth trauma. PTSD symptom severity was assessed with the Post-Traumatic Stress Diagnostic Scale. Anxiety and depression were assessed with a state trait anxiety inventory and postpartum depression scales. Treatment tolerability and safety were closely observed, and outcomes were tracked to approximately 3 months postpartum to evaluate the stability of symptom reduction. Patient A had developed post-traumatic stress symptoms after the lengthy labor of her first child that ended in an emergency cesarean section after unsuccessful vacuum extraction. Patient B suffered a second-degree vaginal rupture resulting in pain and inability to engage in sexual intercourse for years. Patient C developed severe postpartum preeclampsia requiring intravenous treatment. Each of the 3 cases showed significant reductions in PTSD symptoms following EMDR therapy with decreased scores on trauma and anxiety measures. The therapy was well tolerated with no adverse effects noted. Additionally, improvements in mood and mother-infant bonding were observed. Because this was a small case series, there is limited generalizability of the findings. There was no control group. The relatively short follow-up also limited conclusions about long-term impact. This 2012 case series from Stamrud and co-authors provided preliminary evidence supporting EMDR as a safe and effective intervention for pregnant women with postpartum PTSD, leading to beneficial effects on trauma symptoms and emotional well-being. Their detailed case narratives underscored the need for larger controlled trials to validate and extend these findings in the treatment of childbirth-related trauma in pregnant women. Zolgadur and co-authors published the first randomized controlled trial in 2019 evaluating the effects of EMDR therapy on childbirth anxiety among women who experienced a previous stillbirth. Published in the Journal of EMDR Practice and Research, the study addressed the profound psychological impact that a prior stillbirth can have on anxiety during subsequent pregnancies. The researchers enrolled 30 pregnant women with a history of childbirth when they were admitted for delivery in an urban hospital in Qazvin, Iran in 2016. They were then randomly assigned to receive EMDR therapy or routine prenatal care. Those in the EMDR group received a single 90-minute EMDR session conducted in the labor ward shortly before childbirth. Outcome measures included the Pregnancy Anxiety Questionnaire administered before and after the intervention and at 1 month postpartum. The study monitored physiologic indicators of anxiety such as heart rate variability and recorded relevant pregnancy outcomes and participant feedback regarding the intervention. Women who received EMDR therapy showed a significant reduction in childbirth anxiety scores compared to the control group both at completion of EMDR therapy and at the 1 month follow-up. The EMDR group also exhibited better emotional regulation and fewer somatic anxiety symptoms. There were no adverse effects reported, and pregnancy outcomes did not differ between the groups, supporting the safety of EMDR in this context. Limitations included the study's small sample size and single-site design. The short follow-up period limited conclusions about long-term psychological or obstetric outcomes. Zolgadur and co-authors concluded that EMDR therapy significantly reduced childbirth-related anxiety in women with previous stillbirth and did so without adverse maternal or fetal outcomes. Their work supported EMDR's role as a trauma-informed therapeutic option in prenatal care for women facing high risks of psychological distress due to perinatal loss. To explore the question of safety of EMDR treatment of pregnant women with fear of childbirth, Bas, Stamrud, and their co-authors published a multi-center randomized controlled trial in 2023. This study examined EMDR's impact on both maternal and neonatal outcomes in a controlled clinical setting. The study enrolled 141 pregnant women with gestational ages from 8 to 20 weeks with clinically significant fear of childbirth, defined by a WISMA Delivery Expectations Questionnaire score of 85 or higher. Participants were randomized to either EMDR therapy or care as usual at 2 teaching hospitals. Treatment safety was carefully tracked, including adverse events, symptom exacerbation, and obstetric complications. Primary measures included severity of fear of childbirth scores, obstetric outcomes including rates of cesarean section, birth weight, gestational age, induction of labor, and patient satisfaction. Psychological safety was monitored based on rates of dropout, serious adverse events, and suicide risk. Linear mixed model analyses compared EMDR to care as usual, and fear of childbirth was reevaluated post-treatment. Both the EMDR and Care as usual groups exhibited substantial reductions in fear of childbirth symptoms with a mean decrease of 25.6 for the EMDR group and 17.4 for care as usual. Over 70% of EMDR participants and 60% of care as usual participants no longer met diagnostic criteria for fear of childbirth at post-treatment. No significant differences were observed in maternal or neonatal outcomes, including cesarean section rates or birth complications. Notably, the EMDR participants were significantly less likely to request non-medically indicated induction of labor, suggesting potential benefits in managing childbirth expectations and anxiety. There were no clinical indicators of psychological harm or obstetric risk associated with EMDR. This study's generalizability may be limited by its geographic scope to the Netherlands and the decisions to exclude participants with severe psychiatric illness or any history of traumatic birth experiences. The lack of statistical significant differences between groups raises questions about EMDR's added effectiveness beyond standard care for addressing the fear of childbirth. The takeaway message from this 2023 study is that EMDR therapy is safe for treating fear of childbirth and pregnancy with no evidence of increased maternal or neonatal risk. In this study, EMDR produced only slightly greater symptom reduction than care as usual. However, we need to keep in mind that in this study, participants were not selected based on meeting criteria for an anxiety or depressive disorder or PTSD, merely the fear of childbirth. Boss and co-authors published a systematic review and presented a case study in 2020 examining the effects of PTSD treatment during pregnancy. Their research addressed the critical issue of maternal mental health and obstetric outcomes associated with PTSD during gestation. Their review followed a comprehensive systematic methodology searching multiple databases. They included studies that reported on psychological or pharmacological interventions for pregnant women diagnosed with PTSD with outcomes related to maternal mental health or obstetric complications. They also included a detailed case study focusing on a pregnant woman undergoing PTSD treatment to illustrate clinical findings and practical considerations. They collected information on the types of interventions used, such as trauma-focused CBT, EMDR therapy or pharmacotherapy, treatment duration, maternal symptom reduction, adverse events, and obstetric outcomes like preterm birth, low birth weight, and delivery complications. Their case study additionally provided qualitative insights into treatment progress, maternal well-being, and obstetric outcomes following intervention. Their review found that trauma-focused psychological therapies such as EMDR and CBT appeared to be both feasible and safe during pregnancy, with most studies reporting significant reductions in PTSD symptoms and anxiety levels. Their case study demonstrated that targeted PTSD treatment with EMDR therapy reduced maternal distress without adverse effects on pregnancy or neonatal health. Importantly, the authors pointed out that untreated PTSD is associated with higher risks of preterm birth and other obstetric complications. They emphasized the importance of intervention over withholding treatment. The authors acknowledged that the small number of high-quality controlled studies limited the strength of clinical recommendations. The heterogeneity of treatments, timing of interventions, and variable outcome measures prevented offering definitive conclusions. The case study, while illustrative, cannot be generalized to broader populations. Boss et al., 2020, concluded that PTSD treatment during pregnancy, including evidence-based approaches such as EMDR therapy, appeared to be safe and potentially beneficial, reducing maternal trauma symptoms and possibly improving obstetric outcomes. Chesmedev and Farrell, 2023, conducted a narrative review exploring EMDR therapy for pregnant clients with co-occurring substance use disorders. 10 studies met their inclusion criteria. However, they found no randomized controlled trials on the use of EMDR therapy in pregnant women with substance use conditions. The reports they examined ranged from case studies and pilot investigations to theoretical analyses. Reviewed studies used standard trauma assessment measures, supplemented by clinical interviews and follow-up evaluations. Measures of substance use included self-reported frequency and diagnostic assessments. Treatment durations range from 1 to 6 EMDR sessions, typically lasting 50 to 90 minutes, with follow-ups ranging from several months to multiple years postpartum. Across these small-scale investigations of EMDR therapy, reductions in PTSD symptoms and improvements in emotional regulation were consistently reported. Chesmedjev and Farrell found that EMDR therapy can safely and effectively reduce trauma-related distress among pregnant clients, often improving subsequent birth experiences. However, EMDR's direct effectiveness in addressing substance use itself was less conclusive. They suggested EMDR may serve best as part of an integrated treatment model addressing trauma and addiction simultaneously. They discussed potential safety concerns about maternal arousal during trauma processing, potentially affecting fetal well-being. However, these were acknowledged to be speculative, since the existing studies reported no adverse physiological or obstetric outcomes. Limitations of their review included the small number of studies, lack of controlled trials, inconsistent methodological quality, and underrepresentation of pregnant participants. However, their review did suggest EMDR can be an adaptable and ethically defensible trauma therapy for pregnant women, even those managing substance misuse. Before going on to studies about EMDR treatment post-delivery for anxiety and PTSD, let's summarize the findings from these 6 studies in the context of the early concerns over EMDR therapy safety for pregnant women. All 6 of these research studies of pregnant women found that EMDR therapy can be safely offered to pregnant women with no evidence of increased maternal or neonatal risk, and with consistent results showing the effective treatment of PTSD and the fear of giving birth. In addition, the 2023 study from Boss, Stamrud, and co-authors study found their EMDR participants were significantly less likely than those in care as usual group to request non-medically indicated induction of labor. Finally, as Boss and co-authors pointed out in their 2020 study, untreated PTSD is associated with higher risks of preterm birth and other obstetric complications. So the science now indicates that withholding EMDR treatment from pregnant women with PTSD or birth anxiety is the larger risk when considering the evidence that EMDR provides effective, brief treatment of pregnancy-related fear of giving birth and pregnancy-related PTSD. Next, we will briefly summarize 4 studies on EMDR treatment for women with PTSD from traumatic birth experiences. The first of these appeared in 2008. The 3 most recent of these studies appeared in 2025. A study conducted by Chorino and co-authors published in 2020 used a pilot randomized clinical trial to evaluate a brief EMDR intervention compared to treatment as usual for women experiencing post-traumatic stress symptoms following traumatic childbirth. 37 women were randomly assigned to receive a single 90-minute EMDR session or a single treatment as usual session within the maternity ward within 3 days postpartum. Assessments were conducted at baseline, 6 weeks, and 12 weeks post-delivery to evaluate symptom changes and mother-infant bonding. Post-traumatic stress symptoms were assessed with the impact of event scale revised, with a clinical significance cutoff score of 24. Secondary measures included the mother-to-infant bonding scale, the Edinburgh Postnatal Depression Scale, and self-reported flashbacks and distress related to birth trauma. Dissociation was measured at baseline by the Paratraumatic Dissociative Experiences Questionnaire. Both the EMDR and treatment as usual groups experienced significant reductions in post-traumatic stress symptom severity from baseline to 6 and 12 weeks postpartum. However, the number of women who were completely free of symptoms at 6 weeks was twice as large in the EMDR group at 78.9% compared to the treatment as usual group at 38.9%. By 12 weeks postpartum, these group differences were no longer statistically significant, but still favored EMDR. Women receiving EMDR reported fewer flashbacks and lower distress related to recent and anticipated future childbirth experiences. No significant differences were observed between groups regarding mother-infant bonding or postpartum depressive symptoms. The authors acknowledged that the small sample size and the lack of a second active treatment group limited the ability to isolate treatment effects. The relatively short follow-up period of 3 months prevented assessment of longer-term impacts. The sample included only women with live births and excluded those with complex psychiatric comorbidities or neonatal intensive care admissions, limiting generalizability. This study demonstrated that a single session of EMDR therapy delivered shortly after a traumatic childbirth is a feasible, well-tolerated, and potentially effective early treatment for postpartum post-traumatic stress symptoms. The authors underscored the importance of timely screening and intervention within maternity care settings to promote maternal recovery and support early mother-infant bonding. Their findings suggested incorporating brief EMDR therapy into postpartum care could improve outcomes and warranting larger randomized trials with longer-term follow-up to clarify benefits. Cerrudo Caldente and co-authors in 2025 conducted a pilot randomized controlled trial to evaluate the feasibility and preliminary effectiveness of the recent traumatic episode protocol of EMDR therapy for preventing post-traumatic symptoms following perinatal loss. The trial enrolled 40 women who suffered perinatal loss at a university hospital maternity service in Spain. Participants were randomly assigned to receive either EMDR therapy or treatment as usual, which consisted of psychological grief counseling and non-trauma-focused cognitive behavioral techniques. Post-traumatic, depressive, anxiety, and perinatal grief symptoms were assessed at baseline and 3 months after the loss. The researchers used several self-report instruments, including the PTSD checklist for the DSM-5, the Beck Depression Inventory 2, the state portion of the State Trait Anxiety Inventory, and the Perinatal Grief Scale. Treatment satisfaction was measured by the Consumer Reports Effectiveness Score questionnaire. The results indicated that women who received the EMDR intervention scored lower, although not statistically significantly lower, than women who received treatment as usual across all symptom domains at 3-month post-loss. However, the women receiving EMDR therapy reported significantly higher perceived emotional change compared to the control group, indicating greater subjective benefit. The EMDR group also showed trends towards greater reductions in depressive symptoms and perinatal grief intensity compared to controls. Treatment adherence and satisfaction were high in both groups, with no significant adverse effects reported. Women in the EMDR group received, on average, 1 more intervention session than the control group. Limitations included the small sample size. The difference in the number of sessions between groups introduced a potential confound, as did the non-random allocation of therapists and the lack of a no-treatment control group. The authors concluded that the recent traumatic episode EMDR protocol was feasible, acceptable, and well-tolerated in women after perinatal loss. Although no clear significant symptom reductions were observed compared to the CBT control group, EMDR showed promising effects on depressive symptoms, perinatal grief intensity, and perceived emotional improvement. The authors recommended further investigations with larger multi-center trials and longer-term follow-up. Their findings underscored the potential value of early trauma-focused intervention within standard perinatal mental health care. Doherty and co-authors published a retrospective analysis in 2025 evaluating the effectiveness of EMDR therapy for childbirth-related post-traumatic stress symptoms and postpartum post-traumatic stress disorder. The study included 34 women who received EMDR treatment at a specialty birth trauma clinic over a 4-year period at an urban maternity ward in Ireland. Women were screened using the post-traumatic stress disorder checklist for the DSM-5 before and after EMDR therapy. The study investigated symptom reduction, treatment duration, and treatment outcomes. The primary outcome measure was the post-traumatic stress disorder checklist. A reduction of 10 points on the checklist was considered a clinically significant improvement. The study also documented demographic, obstetric, psychiatric comorbidities, and neonatal factors. Data on EMDR treatment duration, number of sessions, and completion status were collected. The results showed a significant mean reduction of over 14 points on the PTSD checklist score after EMDR therapy with a large treatment effect size. Clinically meaningful symptom improvement occurred in 61.8% of participants, and 50% of those initially meeting a PTSD diagnosis prior to treatment no longer met symptom criteria after completion. The mean number of EMDR sessions delivered was 5. Symptom reduction did not correlate with the number of sessions or the interval between childbirth and treatment. The treatment completion rate was over 70%. No demographic, obstetric, psychiatric, or neonatal factors significantly predicted EMDR treatment completion or effectiveness. Study limitations included the retrospective design, reliance on self-reported measures, absence of a control group, and the relatively small sample size. The lack of ethnic diversity and short follow-up period further limited generalizability. The study also did not examine the relationship between trauma symptoms and maternal-infant bonding. The authors concluded that EMDR therapy may effectively reduce childbirth-related post-traumatic stress symptoms even in women with long-standing symptoms, prior trauma, or comorbid mental health issues. The individualized treatment duration appeared sufficient for symptom improvement as the number of sessions did not correlate with effectiveness. The low dropout rate suggested good acceptability. The authors recommended further controlled trials with larger, more diverse samples and longer follow-up to confirm these findings. In this study, EMDR demonstrated promise as a practical, effective intervention for childbirth-related trauma in a real-world clinical setting. Hendricks and co-authors conducted a randomized controlled trial to evaluate the effectiveness and safety of EMDR therapy in women who experienced a traumatic birth. The study, published in 2025, was conducted at a hospital and multiple midwifery practices in Amsterdam. Participants were recruited within 14 days postpartum and randomly assigned to either the EMDR group, which received 2 60-minute EMDR sessions between 2 and 5 weeks postpartum, or to a control group that received standard postpartum care plus 2 brief telephone calls. The primary outcome measure was PTSD symptom severity at 9 weeks postpartum. The researchers measured PTSD symptoms using both the PTSD checklist for the DSM-5 and a structured clinical interview. They also used measures to assess depression, mother-infant bonding difficulties, fear of childbirth, and quality of life across multiple domains. These assessments occurred at baseline and 9 weeks postpartum. Safety was monitored continuously. Demographic and obstetric data were extracted from patient records for analysis. The study found that women in the EMDR group had a significantly larger reduction in PTSD symptoms at 9 weeks postpartum compared to the control group, as shown in both self-report scores and clinician-administered interview results. EMDR therapy also resulted in significant improvements in depressive symptoms, mother-infant bonding, fear of childbirth, and psychological quality of life. No significant differences were observed in breastfeeding rates between groups. No serious adverse events occurred, supporting the safety of the early EMDR intervention. Limitations included the inability to blind participants and therapists to group allocation. There was no long-term follow-up beyond 9 weeks postpartum. The study population lacked ethnic diversity, potentially limiting generalizability. Hendricks and co-authors concluded that early postpartum EMDR therapy was a safe and effective intervention to reduce PTSD symptoms and related psychological distress after a traumatic birth. EMDR treatment significantly lessened depressive symptoms and fear of childbirth while enhancing mother-infant bonding and psychological quality of life. These findings support the integration of trauma-focused EMDR therapy into routine postpartum care to benefit women with traumatic birth experiences and support recommendations for further research into long-term effects and implementation in more diverse populations. There are currently 4 studies of EMDR treatment for childbirth-related PTSD, 1 retrospective records review, 2 pilot randomized controlled trials, and 1 full-scale randomized controlled trial. Together, these 4 studies have demonstrated that EMDR is a promising therapy for childbirth-related PTSD that can be delivered early postpartum, either as a single brief session or with a small number of sessions. EMDR was well tolerated in all 4 studies with high acceptability and no evidence of harm across a range of clinical and research settings. The limitations shared across these 4 studies were small sample sizes, short follow-up durations, and lack of ethnic diversity. This highlights the need for larger multi-center trials with longer-term outcomes and more diverse populations. The convergent evidence from these 4 studies supports incorporating EMDR therapy into routine postpartum mental health care for women with childbirth-related PTSD to resolve PTSD, lessen depressive symptoms and the fear of childbirth, and to enhance mother-infant bonding and psychological quality of life. For the last segment of this podcast, we turn again to the role of EMDR therapy in enhancing maternal-infant bonding. Earlier in the podcast, we examined the work of Stamrud and co-authors who, in 2012, reported on cases of 3 women with birth-related PTSD from their first pregnancy who were treated with EMDR during their second pregnancy. Stamrud and her co-authors described benefits from successful EMDR reprocessing for mother-infant bonding. Also, we summarized work by Hendricks and co-authors who, in 2025, reported improvements in mother-infant bonding compared to care as usual when EMDR therapy was delivered to women with birth-related PTSD in the first few weeks postpartum. Now, let's explore whether maternal-infant bonding can be enhanced months or years after delivery. And could this delayed work with EMDR therapy on maternal experiences of birth trauma have measurable effects on children's health and well-being? These are the questions raised by the work of my Sonoma County colleague, psychologist Antonio Madrid. In his 2006 and 2024 articles, he examined the relationship between childhood asthma and early disruptions in the maternal-infant bond. In the 2024 article, he reviewed research showing that childhood asthma was influenced by perinatal factors and the quality of early mother-child interactions. He summarized large-scale investigations from Finland, Norway, and Great Britain, which confirmed that cesarean sections, pregnancy complications, and ongoing maternal mental health issues all increased the likelihood of childhood asthma. To test whether later therapeutic interventions could improve mother-infant bonds and improve clinical outcomes, Madrid carried out 3 pilot studies where mothers were treated with bonding therapy, which involved reprocessing birth-related trauma with EMDR therapy and then fostering an idealized positive birth narrative. He reported a total of 37 mothers were treated, and 31 children's health improved without being directly treated. After individual bonding therapy for their mothers, he reported children playing without wheezing, having a cold without wheezing, improvement of overall health, and reduction or elimination of asthma medications. Younger children did better than adolescents, potentially due to their stage of development and adolescents' desire for independence. These pilot studies lacked random assignment or a control group, and therefore assessors were aware of the mother's treatment status when assessing treatment outcomes. Nevertheless, Madrid's pioneering research suggests that even delayed reprocessing of adverse birthing experiences and reworking the birth narrative can substantially enhance mother-child bonding and improve asthma outcomes in children even years later. Well, that's it for today's episode of EMDR, the Science Behind the Therapy from Sonoma Psychotherapy Training Institute. We hope this podcast helps deepen your understanding of the clinical science behind EMDR therapy. All the articles covered in this 4th episode of the podcast can be found at sonomapti.com/blog in the November 2025 listings. If you enjoyed this podcast, help support the podcast by following, rating, or sharing it with fellow therapists. For information on our unique EMDR therapy training program, visit sonomapti.com. And for free articles on EMDR therapy, visit the resources section on andrewleeds.net. Thanks again for listening. We'll see you next time.